this opportunity once again to welcome all of you. And even before we proceed, I want to wish everyone a very wonderful World Tuberculosis Day on this day. And having said that, I want to once again welcome all of you to this session. And as I've said earlier, is that we are going to discuss thrombotic risk testing and, of course, monitoring treatment of thrombotic events. So as I've said, that this is a very timely and interesting discussion. And if you will have any questions, you can kindly either bring them on the chat box, and also you can ask your questions at the tail end of the presentation. So I want to say also that today's webinar is very important to all of us because it will bring into focus the essential role of advanced diagnostic testing and also early detection and personalized patient management. So I'm sure we are doing quite a number from coagulation profiles to biomarkers. And I think we have an expert to lead us in this, and this is Agre. And Agre is a distinguished expert, especially in MLS. And I will walk us through these practical approaches and also current best practices and real-world application in thrombotic risk assessment and also treatment monitoring. So once again, let's put our hands together for Agri, even as he continues to lead us in this. So Agri, I hope you can hear me. You can say hi and you can proceed.
Yes, Fred, I can hear you clearly. And thank you for bringing me on board so that we really learn about thrombotic risk testing and also monitoring treatment of thrombotic events. So as you have said that this is a crucial topic that we need to be able to learn and internalize and also sharpen our skills in diagnostic procedures, as well as have a strong acuity to understand what what our role is and what we are doing, especially in laboratory medicine, so that we can save the world. So you're all welcome, so that we can learn together in this topic. So the overview of this discussion will involve a number of issues that we are going to look at risk assessment tests, such as thrombotic risk panels. We're going to look at well score. We're going to understand what well score means, and imaging tests like duplex ultrasonography, CT scans, and MRI, and the role they play in augmenting the laboratory medicine efforts in diagnostic, in making a diagnosis, especially on thrombosis. We are going to look at how lipid profile and liver function play a role in diagnosis of thrombotic events. We're also going to look at coagulation tests, such as APTT, PT, fibrinogen, platelet function assay 100, PFA 100, factor V Leiden, etc. Some of these tests we do them routinely, and some of them are somehow specialized. And also the role of complete blood count, which is routinely done to diagnose other issues. But also, we actually, some of us at least understand that CBC can play a big role and major role in diagnosis of thrombotic events. It's one of the key tests that is used in thrombotic risk testing and also monitoring of thrombotic events. So as introduced earlier, thrombosis is a major cause of morbidity and mortality world over, not only in Kenya, but world over. And there are various types of thrombosis. We have deep venous thrombosis, pulmonary embolism, and also arterial thrombosis. Arterial thrombosis encompasses of myocardial infarction and stroke. Thrombosis is an event. If I can define thrombosis, this is an event whereby the blood vessels are clogged by accumulation of certain substances associated with the low density lipoprotein accumulation and prevention of blood flow along the blood vessels. There are other events that are usually involved in making or in bringing thrombotic events into the picture, like accumulation of platelets. There are also epithelial, the issues with injury to blood vessels and accumulation of platelets along the lumina of blood vessels, and many other issues that come into play, issues concerning the coagulation cascade. Now, but here we are going to focus on thrombotic events and how we are going to diagnose it, and leaving out nitty-gritties concerning coagulation cascade and coagulation pathways. There are risk factors that lead to development of thrombotic events. Such factors can range from genetic to lifestyle. We have genetic factors such as factor V Leiden, prothrombin mutation, and also protein C stroke S deficiency. We also have acquired antiphospholipid syndrome. Cancers can lead to thrombotic events, also pregnancy and also obesity. There are lifestyle issues that can also cause thrombotic events, such as smoking, immobility. People live sedentary lifestyle. They don't want to exercise. They don't walk. They don't involve themselves in sport activities. Some of these people can also be immobile due to illness and such issues. Also, we have oral contraceptives, which also play major roles, especially in women who take them. They play a role in development of thrombotic events or in thrombosis. There are various methods that are used in testing of thrombotic events or thrombotic risk testing. We have coagulation assays such as prothrombin time, that is PT, where we do in the same PT, we also obtain INR. We also have APTT. Fibrinogen testing is also very important in this. We also have genetic factors, as mentioned in previous slide, that we have factor V Leiden inheritance, or the inheritance of this factor can lead to can be a risk factor in thrombosis. We also have prothrombin mutation, which is an inherited mutation, which can also be a risk factor. We have platelet function tests like platelet aggregation, bleeding time, And also, yes, these are key, especially in diagnosis of thrombotic events or checking on the risk to thrombosis. Other biomarkers like D-dimer, prothrombin, antithrombin complex are also important in this. So for us to comprehensively make decisions on diagnosis and management, the clinicians will mainly rely on various diagnostic procedures that come in. These diagnostic procedures will help in identifying the risk or making a diagnosis, or even ruling out any risk or any thrombotic event. We have thrombotic risk assessment tests. We have laboratory thrombotic risk panels that we'll look at. Also, we have thrombotic risk tests like duplex ultrasonography, CT scans, and MRI, which are also come together from imaging to be able to make a comprehensive diagnosis. And this one can lead also to make a decision, critical decision on diagnosis and management. After making a diagnosis from the lab plays a major role. Actually, over 70% of clinical decisions, especially in thrombotic events management or diagnosis, will come from laboratory medicine. Other reports from imaging will help in managing the condition, or making a decision on the approach that can be used in treatment, or pinpointing where the events have occurred, especially in the body, so that clinicians know what to target and how to manage these events. We have well scores, which usually come from the clinical history of the patient, and we look at what well scores means and how they are used, especially in narrowing down on which tests can be done and how the diagnosis can be approached. Having said about well scores, this is an example of well score for deep venous thrombosis. Well score, as I've said, that it comes from clinical history. Like as you see in this table, this is a well score chart that describes the risk factors as perceived or received from the patient's clinical history. Like now, you see there is active cancer. This patient has active cancer, so you give a score of 1. Paralysis or paresis, recent cast or lower extremity, that's positive 1. Recent immobilization that lasted for more than 3 days or surgery within the past month, you see it has been given 1 score. If it's absent, there is no score there. Localized tenderness or deep venous system. We also swelling, it's like symptom of swelling on the entire leg, calf swelling more than 3 centimeters compared to non-swollen leg, pitting edema, collateral superficial veins, prior DVT, alternative likely diagnosis. You see, these have been given scores because they are present in this patient. And when the score is well over 2, it means that deep venous thrombosis is likely. When you look at all those events as chronicled in clinical history, they are well over 3. So that means that this person is likely to have DVT. So this is an example of well score, and this specific for DVT. What about arteriovenous thrombosis? What about other issues that deal with thrombotic events, associated with thrombotic events? They can also have their well scores. So that's what clinicians do to reach a decision on what test to request for and what how to handle results that especially have come from the lab or from imaging, and especially on management or treatment of thrombotic events. We are going to look at interpretation of test results, especially when we have abnormal results that indicate increased thrombotic risks. Also, we are going to understand that normal results do not rule out, because there are other things that come in. The clinical history comes in. Also, there are other tests that can come in, other alternative tests that may be requested by the clinician that will come in handy to make the clinician reach at a decision of diagnosis. Especially, you've done INR, that's prothrombin time, and you found it's normal. But there are other tests that, like fibrinogen, there are other tests like APTT. We're going to look at them, how they come in. APTT can be abnormal, but and PT can be normal. How do you define that? So that's why there are other tests that come in, so that to enable us be able to make a comprehensive diagnosis. Now, we're going to begin with prothrombin time. The prothrombin time measures blood clotting time, specifically how long it takes for prothrombin to convert to thrombin. It's a crucial test to evaluate bleeding risks or monitor anticoagulation therapy. So prothrombin time, as we all know, is others call it INR, but it is called prothrombin time. It's used to monitor, to evaluate bleeding risks or monitor anticoagulation therapy. Now, what we are going to ask ourselves, prothrombin time, it's more or less a routine test in many hospitals, especially hospitals that handle patients, inpatients, with a varied, a wide range of diseases, from actually level 3 hospitals. These level 3 hospitals and above, these coagulation profile tests are more or less like routine tests. What does prothrombin time check? It checks clotting factors like 1, 2, 5, 7, and 10. 1, 25, 7, and 10. The easiest way to remember prothrombin time is to know about factors 1, 2, 5, 7, and 10. When it's abnormal, then these factors are abnormal, can be abnormal in the system. We also have liver function. That prothrombin time can also be used to check the liver function, because liver function plays a key role in metabolism and production of certain liver associated factors, such as prothrombin production, platelet production, and many other factors. There are factors that are liver dependent. It is also used to check the effectiveness of anticoagulant medications such as warfarin or coumarin, And when the prothrombin time has been requested, we often have to inquire, or we need this clinical history, whether this patient is on warfarin therapy. So it's very, very key for us to know that, so that it helps us to report. Because if the clinicians receive the report, there has to be an indication whether this patient is receiving warfarin or not, because the results are dependent on this. And the interpretation of these results are dependent on whether the person is under treatment or not. The normal range typically ranges from 10 to 14 seconds. Also, we have the INR part. The INR part ranges from 0.8 to 1.2. But this one varies on the lab and medication. That's why I was saying, talking about medication. It should be well noted whether the patient is under medication or not. Remember to communicate critical results. The critical results threshold should be unequivocally stipulated in PT-SOP. So this is one of the priority tests, and it should be reported, critical results should be reported, because critical results can mean a matter of life and death. So they should be reported and unequivocally stipulated or clearly indicated or documented in prothrombin time standard operating procedures. Now, we can ask ourselves, what if the results are normal, that prolonged PT indicates bleeding risks, liver disease, or vitamin K deficiency, or anticoagulant therapy. Shortened PT can indicate clotting risk, dehydration, or cancer. The second assay we are going to look at is fibrinogen assay. This is a test that measures fibrinogen levels in blood. It's a crucial clotting protein. Fibrinogen helps form blood clots to stop bleeding. We know about fibrinogen that it's one of the factors that are in plasma that enables clots to form. Fibrinogen, it checks fibrinogen deficiency. In fibrinogen assay, we are going to check on fibrinogen deficiency or fibrinogen dysfunction. And this, as in this assay, we also going to check on bleeding disorders like fibrinogenemia, where we don't have fibrinogen at all. It also checks on DIC, that's disseminated intravascular coagulation, liver disease that can be associated with fibrinogen production. The normal range of fibrinogen results should range between 200 to 400 milligrams per deciliter, and this one varies from the lab and the population the lab serves or the hospital serves. Low fibrinogen indicates bleeding risks, liver disease, and disseminated intravascular coagulation. High fibrinogen indicates inflammation, infection, cancer, pregnancy. The abnormal results may require further testing or treatment. So when we talk of fibrinogen also has to be known as an acute phase protein, just like C-reactive protein, among others. It's a C-reactive, it's one of the acute phase proteins like CRP, procalcitonin, and among others. So that's why we are talking about inflammation, infection, cancer. Abnormal results may require further testing or treatment. So you see, it's very crucial for us to do fibrinogen as an assay, because it can help the clinicians to really know what to target. The third test is activated prothrombin time test, the APTT. This test evaluates blood clotting specifically on the intrinsic pathway. So while prothrombin time tests extrinsic pathway, we talked of factor 1, 2, 5, 7, and 10 in prothrombin time. In activated prothrombin, in partial thrombin time, that's APTT, we are going to look at factor 8, 9, 11, and 12. That is what it checks in the extrinsic pathway. So you see how they differ with the iron, with the prothrombin time. That's the difference. Also, APTT monitors heparin therapy. It also checks on bleeding disorders such as hemophilia A and B, and also lupus anticoagulant present. The typical reference range for APTT ranges between 25 to 35 seconds. Now, abnormal results will mean that there is heparin therapy, clotting factor deficiency, and lupus. So again, we are going to compare it with the PT. PT, especially when we are monitoring treatment, it checks on warfarin therapy, but APTT checks on heparin therapy, among other issues that I've just mentioned, dealing with intrinsic pathways and factors that I've talked about, factor 8, 9, 11, and 12. Also, lupus anticoagulant, which is also very important, is good for us to dig deeper into other issues dealing with coagulopathies. When we read further, that can be a take-home assignment to read further about lupus anticoagulants and how it affects clotting and bleeding disorder, bleeding physiology. Shortened APTT indicates clotting risks, pregnancy, and cancer. It can be used to monitor heparin therapy and diagnose bleeding disorders, as I've mentioned. So that is APTT. And you've seen the difference between APTT and PT. And also we have discussed issues pertaining to fibrinogen and what the role that fibrinogen, among other markers, what they play in diagnosis of coagulopathies and thrombotic risks. Now we are going to look at clinical utility of APTT. It identifies risks, patients who are at risk of thrombosis, and also guides anticoagulation therapy such as heparin. It reduces morbidity and mortality. Also, thrombotic risk testing is essential for identifying patients who are at risk. So it leads to early detection and management and can prevent thrombotic events. Management and prevention of thrombotic events, such as we have anticoagulation therapy, antiplatelet therapy, lifestyle modification, exercise, weight management, and smoking cessation. So it's good for us to know, apart from playing a key role in diagnosis and helping to monitor treatment of such events, it's important for us to understand also the way we can take care of our health. And also that maybe there are close people, people who interact with close spaces, especially can be patients we know, friends we know, family, people from the family circles. We can help them, maybe give an advice on lifestyle modification, exercise, weight management, and smoking cessation. These are things that are also can also be dear to us, because also for us as medical laboratory practitioners, we need to be safe. We need to know what to do in order to prevent falling into thrombotic risks. So we take care of our health. So if you are smoking, you can stop smoking. If you're overweight, you can check on weight management and also exercise, and various issues dealing with the lifestyle modification, such as nutrition and diet. We also have a factor V laden test, which talked about inheritance of certain conditions that put us at risk or put humanity at risk. Factor V laden test detects a genetic mutation in factor 5, a clotting protein. The mutation increases the blood clotting risks, leading to thrombophilia. It checks on factor V laden mutation, that's R506Q. So this mutation that we are going to look at, and this also checks on inheritance thrombophilia risk, having inherited that factor, that mutation. Also checks the risk of DVT or pulmonary embolism. This, especially factor V laden or factor 5 laden mutation, is done under molecular biology or genetic testing. So it's a specialized test. Yeah, that's available within the country. Who should be tested for this factor? These are individuals with family history of thrombosis and recurrent DVT or PE. Thrombosis at young age also can be queried for testing. Also unexplained pregnancy loss. This is whereby clinical history is key. So the quality of diagnosis will start from taking the clinical history, and this one will come from clinicians. Because that's from where we are able to identify people with family history of thrombosis and also recurrent DVT or pulmonary thrombosis, pulmonary embolism. And anyone maybe in the family who has been able to have to be at risk of such an event, and the clinical picture indicates towards that. Having said that, also let us keep in mind that there are scores that they use, especially the Wells score. Next, we are going to check on platelet function tests. And these are, they fall into two, the platelet aggregation test and also bleeding time. Bleeding time evaluates platelet function and primary hemostasis. It measures time of bleeding, time for bleeding to stop after a small incision. Now, this is used to check platelet disorders such as VWD, that's von Willebrand's disease, and also to check bleeding risk assessment, and also effective rate of platelet function inhibitors such as aspirin. The procedure is that we make a small incision on the forearm, or we can make either 1, 2, 3 incisions on the forearm, so that we monitor the time these incisions take in order to stop bleeding. Then we put a pressure cuff inflated at 40 millimeters of mercury, and we record time until bleeding stops. This is a common procedure that is used in low resource laboratories, but may be replaced by other highly precise tests like platelet function tests, assay 100, especially in the labs that are well resourced. Now, having mentioned about platelet function assay, especially in platelet function tests, this is an assay that evaluates platelet function and primary hemostasis. It is more sensitive than specific alternative to, and also specific alternative to bleeding time tests. It checks platelet function disorders such as von Willebrand's disease, Glanzmann's thrombocythemia. It also checks on the effectiveness of antiplatelet medications such as aspirin, clopidogrel. Also is another drug that is used in treatment of thrombotic events. There are also other assays like aspirin assays. Also, clopidogrel can also be monitored in the lab by testing, especially in drug monitoring, especially when maybe when issues indicate that we need to do this testing. Can be due to maybe overdosage. The efficacy of the drug can be done. These tests can be done in order to monitor treatment and monitor management too. PFA assay can also be able to check bleeding risk assessment. So the procedure is that we draw blood into a cartridge, and the cartridge contains a membrane with collagen and epinephrine or ADP. We check the time, we also monitor time, and we record until the platelet plug forms. That's closure time. Remember, in the past, I don't know whether some labs are doing it, but it can be done in a very manual way, where we used to do tube clotting time tests. But this one is an assay that's well advanced and a modernized form of clotting time tests. But this is very specific and very accurate. We cannot compare it with the manual tube clotting test. So blood is drawn without any anticoagulant and is put on a cartridge and put into the machine, and to monitor the time it takes for the blood to clot. So that is what we call the closure time. So the reference range of this closure time ranges between 60 and 160 seconds. It varies depending on the cartridge and lab, and the population that the laboratory or the hospital serves. Now, what do abnormal tests mean? The prolonged closure time, maybe what closure time below 60 seconds will mean that there is platelet dysfunction or von Willebrand's disease or antiplatelet medication use. Shortened closure time. So I meant prolonged closure time above 160 seconds, sorry. So the second one is closure time well below 60 seconds, which is not typically clinically significant. It's used to diagnose and monitor platelet function disorders and antiplatelet therapy. So this is a schematic diagram showing a PFA assay, PFA 100/200, and this is the working principle of platelet function assay. as you can see, blood is inserted into a cartridge, and this is how the blood flows. You can see that arrow, how the blood flows. And as the blood flows through this capillary, it encounters epinephrine or ADP, and also a membrane coated with collagen. And when it encounters a membrane coated with collagen and epinephrine or ADP, these elements will trigger clotting. And when blood passes through this, and blood passes through this cartridge through a certain pressure, and there is destruction of, and there's impediment of the flow of blood. And this impediment through these smaller apertures will make platelets adhere to the collagen surface and lead to cessation of blood flow. And when there is this cessation of blood flow, the cessation of blood flow will lead to clotting. And that is, the clotting will now mean closure time. So that's another diagram that shows how blood flows through a cartridge, through how very considerably high shear stress, and accumulation of platelets and cessation of blood flow, leading to closure time. The next, we have D-dimer test, which measures levels of D-dimer protein in blood, which is produced when blood clot dissolves. D-dimer is used to diagnose or rule out conditions like DVT, PE, or DIC. Elevated D-dimer can be an indicator of inflammation, recent surgery, pregnancy, or cancer. D-dimer is used in emergency situations where symptoms like swelling, pain, shortness of breath, or suggestions of blood clot. So it's a very important test that it's usually a priority test that and it should be treated as so, because it can be life-saving in emergency situations, especially when such conditions of thrombotic risks or thrombotic events are in focus. D-dimer reference range depends on specific laboratory and testing, and also as I've been mentioning in other parameters, it can the reference range can depend on the populations we serve. The most commonly accepted threshold for ruling out blood clot disorders is 500 nanograms per ml. However, there is an age factor that comes in, so we have to have age-adjusted D-dimer reference ranges that are often used in older patients. And this one we should be taken into focus, especially when we want to ensure that there is diagnostic accuracy. For example, individuals over 50 years old, the upper limit can be calculated as their age is multiplied by 10 nanograms per ml. Understanding the results reference range helps in decision making, especially to confirm or rule out clot-related conditions. So this one brings into focus, especially when we deal with the systems that are AI enabled, and we can be able to quickly calculate the risk, especially with older patients. See, dealing with that example, people who are aged over 50 years, when we have algorithms that helps us to calculate the reference range, especially when we have issues dealing with age adjustment, they can greatly help us so that we don't release results without proper interpretation, and also because some of these tests may need proper interpretations for handy critical decision making, especially when there is no time for the clinicians to calculate. There is a test like a lipid profile, which plays a critical role and also a significant role in thrombotic risk testing or thrombosis risk testing. This is a routine test. We put into focus low density lipoprotein cholesterol and also HDL cholesterol and also triglycerides. Low density lipoprotein is high. It's also put into high consideration, especially when you look at we are focusing on the risk, because high levels increases the risk of atherosclerosis, which is a contributing factor to thrombosis. High density lipoprotein is a scavenger that removes cholesterol from circulation. So the low levels of HDL, that means that we don't have scavengers that sweep cholesterol from the system, that sweep LDL from the system. The low levels will indicate a risk to thrombosis, because these are very important protein that should be available in blood, in our circulation, for our safety, because of getting rid of dangerous LDL. We also have triglycerides, which is a marker that it's used to indicate in which high levels are indicators of thrombotic risk. And also triglycerides is also a marker that's so much helpful in monitoring glucose metabolism, or even diabetes treatment. Abnormal lipid levels may indicate increased thrombosis risk, guiding preventive measures or treatment. Here is a general guide to reference ranges for lipids, and this is sourced from American Diabetes Association. So this is current. This one can be usable. If you need them, you need to have this. It's important. You know, it's very important for us to give recommendations, especially when we are in our reports. It's very important for us to give recommendations on what we know as laboratory medicine that can help in making decisions. So it's not wrong for you to release a lipid profile report with such recommendations that lipid profile reference ranges, total cholesterol desirable should be less than 200 milligrams per deciliter, borderline high 200 to 239 milligrams per deciliter, high should be greater than 250 milligrams per deciliter. LDL also, you can see those reference ranges as quoted there, and the source is American Diabetes Association, and this is current, as I've said. So we also have high density lipoprotein, as you see there. Low shows increased risk to thrombotic events. So high value means protective. The person is protected, so it should be greater than 60 milligrams per deciliter. Triglycerides, normal should be less than 150 milligrams per deciliter, and we can see borderline high, high, and very high. And those reference ranges are from American Diabetes Association. So we should take note that reference ranges may vary depending on the laboratory and the populations that we serve. So when we talk of laboratory, it doesn't mean that what we are doing in the lab, or it differs that what is being done in Australia. No, it means that the populations that we serve, the locations that we are in, the locality. And to some extent, a small extent, on the equipment that we use, but they play a role that is minor role in making the difference, making those differences from one region to another. So there are other factors that are modifiable, risk factors that include lifestyle, etc. Maybe someone is smoking, maybe drinking, or someone living sedentary lifestyle, immobile person. The risk varies with such kind of indications. Liver function tests play a key role in thrombotic risks or thrombosis risks testing. They help to evaluate the liver's role in blood clotting and identifying underlying conditions that may contribute to thrombotic risks. The key components of liver function tests are ALT, AST, ALP, bilirubin, albumin, and prothrombin time. ALT, or alanine aminotransferase, or alanine transferase, may indicate elevated levels indicate liver damage or inflammation, as we know. Specifically, when we are doing a liver function, we are checking on whether the liver is functioning well. So elevations and elevations of these enzymes help us to understand how what the liver condition, how the liver condition is. But at the back of our mind, you will understand that the liver processes so many things, including coagulation proteins, coagulation factors, including also platelets. They are processed from the liver. So when the liver is malfunctioning, there are some enzymes such as ALT and AST that will be abnormal. Now, bilirubin may indicate that the liver is dysfunctional or there is hemolysis. What causes hemolysis? There are factors associated with coagulation or coagulopathies that can lead to hemolysis. So hemolysis can be a risk factor to thrombotic risk, can be a factor to understand the thrombosis or thrombosis risk. Albumin is an indicator of liver dysfunction or malnutrition, because albumin is processed by the liver. Low levels may indicate liver dysfunction or malnutrition. Prothrombin time and international normalized ratio, that's INR, abnormal risk may indicate coagulation disorders. So INR is another, or prothrombin time is another, it's another test that can be used to assess the liver function. And also being among other tests that are used for testing coagulation issues or thrombotic risks, it can be a liver function test. Liver function can affect coagulation factor production, increasing bleeding or clotting risk. Liver disease can lead to decreased production of anticoagulants, proteins like protein C, protein S, and antithrombin, among others, that especially the ones that I mentioned earlier, like platelets and also coagulation factors. liver can help to liver function can help to identify underlying conditions such as cirrhosis, hepatitis, liver cancer, which may be a contribution factor to thrombotic risk. The clinical implication of liver function tests, that abnormal tests may prompt further investigation for underlying liver disease or coagulation disorders. Liver dysfunction may require adjustments to coagulation, anticoagulation therapy, or other treatments. Another test is complete blood count, which is a routine test that's very key in assessment of thrombotic risk and also monitoring the treatment and management of thrombotic events. That complete blood count plays a key role in assessing thrombotic risk by providing readily available low-cost and rapid measurements of blood components that indicate prothrombotic states, particularly in arterial venous thrombosis, as well as cancer-associated thrombosis. While often used for initial assessment rather than definitive diagnosis, specific CBC parameters, their ratios and hematological indices act as biomarkers for assessing the risk of thrombotic events. White blood cell count increased. White blood cell count, particularly elevated neutrophils, are associated with higher risk of arterial thrombosis. A high leukocyte count is a key marker for immunothrombosis, the role of innate immune cells in clotting, and represents pro-inflammatory states that contribute to thrombotic pathway. Platelet count, as we all know, and is the one that we usually have a quick glance at, especially when you are talking of coagulopathies or thrombotic events. This can indicate, high platelet count can indicate increased risk of clotting, particularly in patients with cancer. Conversely, in some clinical settings, such as hematological neoplasms, lower platelet count may be related to bleeding risks, while slightly higher counts are linked to thrombotic events. We also have these indices, such as red cell distribution width. An elevated RGW is a significant marker for deep venous thrombosis. Having said that, we have mentioned about red cell distribution width, and there is another factor that another index that I'm going to talk about, though I've not mentioned here, and that's platelet distribution width, which is usually available in our complete blood count, which shows how the varied sizes of the variation in sizes of platelets can be an indicator of whether we are dealing with abnormal platelet function or abnormalities in or platelet aggregation problems that is usually an indicator of thrombotic risks, or as a marker of an impending thrombotic event. So platelet distribution width is very important. Of course, it's often overlooked, but it's very important. And also, complete blood count can be overlooked by some, because few people know that CBC, the liver function, can be very key in diagnosis of thrombotic events or risks associated with thrombosis. It's high time that we understand that these are very key in diagnosis of thrombotic events or even checking on the risks. Other indices such as neutrophil to lymphocyte ratio NLR is a key marker and significant predictor of venous thrombotic venous thrombotic events, especially in cancer patients with a neutrophil lymphocyte ratio that are out of reference range. Platelet to lymphocyte ratio is another factor that is important. This can be a derived index that we can do a calculation that higher platelet lymphocyte ratio are associated with acute DVT with PLL, platelet lymphocyte ratio of greater than 180, often suggested marker of intermediate to high risk. Systemic immune inflammation index, that's SII, is calculated as NLR. That is neutrophil to lymphocyte ratio. So this is also another element that we are going to we should consider, and also we check on reference ranges to check on the risks. Platelet counts, also as I've mentioned earlier, is associated with massive pulmonary embolism, especially in high platelet counts. You can platelet counts that are especially considerably high, especially greater than the reference ranges, especially when we are talking about critical value reporting. We need to check on thresholds on platelet counts that should be reported as risks, critical values. As critical values. Platelets greater than 600 are considered as critical value, and these people can be in a very great risk of developing thrombotic events, as well as platelets that are below 45, which are usually indicators of abnormal bleeding and bleeding that can lead to death. That's an indicator of abnormal platelet function and should be treated as critical values. Although low platelet count is not associated with thrombotic risks, as high platelet count indicates, they should be treated with urgency because they can lead to abnormal bleeding and also fatal bleeding. We should we should bear in our minds that CBC is not a standalone. CBC is augmented with other tests such as D-dimer, Doppler, ultrasound, CT, angiography to aid in diagnosing DVT or pulmonary embolism. There are other confounding factors such as inflammatory conditions that may be indicated in clinical history, such as well scores that we looked at, other lifestyle conditions such as smoking. And these parameters, when they come into play, these parameters will help us to carefully interpret what is at hand. So far, we've looked at essential aspects of thrombotic risk testing. We've looked at thrombosis risk assessment, the D-dimer, thrombotic risk tests like duplex, ultrasonography, CT scans, MRI, in a brief view, we've looked at lipid profile, liver function, we've looked at coagulation profiles and associated tests. And the key takeaways, having looked at this, the key takeaways are that thrombotic risk testing helps to identify individuals at risk or at increased risk of developing blood clots, that lipid profiles and liver function tests provide a valuable information about underlying conditions that may contribute to thrombosis risk. Therefore, accurate diagnosis and management of thrombosis risk requires a comprehensive approach, including medical history, physical examination, and laboratory testing. So clinical implications also are very important because they identify and for us to identify and manage underlying conditions such as liver disease or lipid disorders is very key for us to understand what's in picture. The clinical implications usually helps us to prevent measures like anticoagulant therapy or lifestyle changes to reduce thrombosis risk to the subjects who are involved. It can help to monitor patients with history of thrombosis or at risk for recurrence. So I've come to the end of my presentation. So the most important thing that we should take note is that when we talk about thrombosis or thrombotic risks and the diagnostic procedures that are involved, there are certain tests that are usually done routinely that people come to the laboratory or to the hospital for testing, like there are profiles that have been in picture, like well-man, well-woman, wellness profiles that people come for diagnosis, for testing, just routine testing to check on their well-being. And these tests are usually done regularly. It's very important for such patients after that to see maybe to see a physician or a cardiometabolic specialist or to see an internist so that these tests are evaluated. It's not that the patient checks on the results and the person goes home. They are normal and the person goes home. Maybe lipid profile is more or less okay, liver function more or less okay, but there are key indicators, maybe in blood counts or something like that, that are usually overlooked because the person is focusing on maybe cardiovascular conditions. And the patient might be at risk without knowing. So it's good for us to also have knowledge and also refer these people to go back and see their physicians. So having come to the end of my presentation, I know there will be a session for questions and answers, and I'll take this back to our moderator. Fred, kindly take it up. If you can hear me. Hello? Hello, guys. I hope I'm audible. I hope I'm not lost. Hello? We've come to the end of our presentation. Kindly, if there are questions, okay, thank you, Fred. Thank you for that response. Now I know that I'm online. If there are questions and answers or any comments, kindly just you can weigh in. Thank you, Daniel. I can see your comments. Amos, thank you. Thank you, Betty. If there is any question, any comment, you are welcome on board. Your contribution is very important for us to learn. We also learn from each other. Thank you, Joseph, Nilesh, Geoffrey, Elizabeth, I can see you. Thanks, guys. Thanks, guys. Any question? Any comments? You are welcome to weigh in. Yes, I can see that comment about D-dimer. D-dimer is a product of the breakdown or degradation during fibrinolysis. Yes, it's very helpful in diagnostic as a diagnostic measure of thrombotic events. Can be also a cancer marker depending on the clinical picture that is at hand. Kindly difference between coagulation profile and D-dimer. Okay, this question is not, okay. What I can say about coagulation profile, coagulation profile as we've coined it, I think it should be a routine coagulation profile, the way it has been coined, so that it involves tests like platelets, prothrombin time, thrombin time, and also activated prothrombin, partial thrombin time. That is the coagulation profile that we commonly handle routinely. However, when we talk about advanced diagnostic procedures for coagulopathies, is now when we come to other tests like factor 5 Leiden factor, we have D-dimer that's come in. We have actual testing of even coagulation factors. Yes, we protein C assays, protein S assays that come in. They fall in coagulation, but they are not among the routine coagulation profile that we usually talk about. So these are advanced. Okay, a little bit advanced coagulation tests that we do, as mentioned, with other specialized and advanced tests that we're talking about, as I've mentioned. Keter, I can see. Thank you. Thank you for that, Bernard. I've clarified that. So, Fred, if you can hear me, please weigh in. If I can emphasize on something that clients who come for regular checkups that are usually done annually or something like that, there are some key elements that can help us to be able to check on thrombotic risks, or to assess the thrombotic risks, and also be able to provide timely diagnosis. Especially, we've talked about CBC, which is a test that cannot be missed, especially on wellness checkups, liver function, lipid profile. Those tests are usually key. They are always available in the tests that we do, especially the routine tests that we do for wellness checkups. That's why they are included in such profiles, because they can pick thrombotic risk early in advance before the patient falls into certain complications associated with such, and now goes to seek medical interventions when things have gone wrong. So having said that, maybe I cannot be able to hear from, I'm unable to hear from our moderator.
Yeah, I'm here, Agree.
All right. Okay. Thank you. Thank you. You are welcome on board, Mr. Fred, so that you can take it over before.
Thank you.
Yes.
Yeah, I think this was quite a good job done. And it was a very wonderful presentation anyway. And I can see a lot of comments towards that end. And also I can see you have attended to the question that was there in regard to the difference between coagulation profile and D-dimer. And also thank you, Dr. Gatua, for the comment, especially in regards to D-dimer, and you say that it's not a protein produced by the liver, but rather one of the degradation products produced during fibrinolysis. And I want to thank you for that. So there's a question here from Amos Kamau. Are there other FDPs other than D-dimer, Agree?
There are, other than D-dimer, there are fibrin degradation products. Of course, fibrin is among other tests that can be done to check on thrombotic risk testing. Although it's not a fibrin, there are fibrinogen degradation products also that can be done. Also, it's an assay that can be done so that we check on thrombotic risks. Although I've not been able to incorporate it into this presentation, the other, as I've said, fibrin degradation products can be done so that we assess the risks of thrombosis.
Thank you, Agree. I think that's clear. And I'm wondering whether there is any other question or comment. You can probably slide in the chat box and just ask your question, or you can alternatively, I can see Dr. Gatua, you have a comment. Maybe I'm going to give you a minute, and maybe you can weigh in and just maybe make a comment. You can unmute Dr. Wilfred and just say something. Thank you.
Thank you, Fred and Marube, for the good presentation. I just wanted to make a comment on the D-dimer. I think I have made it on the chat box. And the other comment was about the other FDPs that are usually measured apart from a D-dimer. Apparently, we only have D-dimer currently that is routinely done, but we also have others like fragment X, Y, and D and E, but they are rarely done. But D-dimers serve the purpose very well. Thank you.
Very well,
Thank
very
you.
well, very well. Thank you so much. I don't know whether there is any other concern or a question. You can raise your hand or slide into the chat box. We shall be able to discuss. Remember, this is just a discussion that is open, and I think generally it was a very enlightening presentation, and I think it allows us to remain curious, informed, and above all, we stay committed to saving lives through quality practice. So if there is no further comment, I'll take this back to you, Agri, for your closing remarks.
Yes, my closing remarks at the backdrop of the understanding about thrombotic events. Thrombotic events are very key, especially in causing morbidity and mortality world over. It's very key for us to understand the risks involved and also take preventive measures. As I said, that prevention is better than cure. So for us to be safe, for us to be safe, to be available, to practice this profession, to help others, is for us to bear in mind that we should be safe first, safety first, before safety for others. So let's take precautions on lifestyle, and also having known everything associated with the risks and prevalence of risks. I've not put here the statistical analysis on cardiovascular events or cardiovascular diseases, especially associated with thrombotic events, but it's a major killer globally. And also we should take preventive measures for us to be safe. So that's my parting shot today. Thank you, everyone.
Thank you, Agri. Thank you, Agri. I think that's a very wonderful parting shot. And I want to also take this opportunity to extend our sincere appreciation here at LMSK to you for this enlightening presentation. And also want to thank all participants for their engagement and also their dedication to learn. And I'm sure this discussion has, to some extent, deepened our understanding. And at least we shall have a better and improved patient outcomes. And I think this will also influence, better decision making and strengthen the quality of care that we deliver. Otherwise, from our desk here, we want to say thank you to everyone, and until next time, enjoy your evening. Thank you.